Sajan K. Sebastian. He has done his MBBS from Government Medical College, Thiruvananthapuram, MD Anesthesia from Christian Medical College, Ludhiana, Punjab. He has a fellowship in cardiac critical care and fellowship in ECMO. He is presently working as consultant cardiac anesthetist in Daya General Hospital, Thrissur. He is also consultant anesthetist, Thrissur District Cooperative Hospital and Ashwini Hospital, Thrissur. We welcome you, sir.
During our resuscitation, even if the patient revives, the 24 to 72 hours, it is critical, as we all know. So we will be pumping up with the fluids to maintain the MAP, CVP, and also giving the inotropes, and the patient will be in a 50-50 stage. In this case comes the deresuscitation. This word is new. It is coined in 2014, and there are 3 definitions which I got from the literature. First one is late goal-directed fluid removal, or that is aggressive and active fluid removal by means of diuretics and renal replacement therapy with net ultrafiltration. It was from Melbourne et al. In 2014. And deresuscitation is also characterized by discontinuation of invasive therapies and a transition to a negative fluid balance. It can be also termed de-escalation. And the third definition was late conservative fluid management is defined as 2 consecutive days of negative fluid balance within first week of ICU stay and is an independent predictor of survival in ICU patients. The complications with coming to the positive fluid balance. Positive fluid balance is a state of fluid overload resulting from fluid administration during resuscitation and subsequent therapies. Fluid overload is defined as a cutoff value of 10% of the fluid accumulation, as this is associated with the worse outcomes. Percentage of fluid accumulation can be defined by dividing the cumulative fluid balance in liters by patient's baseline body weight and multiplying by 100%. Positive fluid balance is associated with worse morbidity and mortality in multiple studies, worse overall mortality in critically ill patient, increased mortality in patients with AKI in SOAP study, prolonged recovery in patients with ALI and ARDS in FACT trial, improved mortality in ARTSNet patient if they had negative fluid balance at day 4, worse mortality in septic shock patient in VAST trial, worse morbidity in colorectal surgery patient associated with intra-abdominal hypertension. Coming on to the fluid accumulation syndrome, the pathophysiology associated with cardiovascular system is increased myocardial edema, conduction disturbances and impaired contractility, increased pericardial effusion, diastolic dysfunction, CVP and PA pressure increased, venous return is decreased, stroke volume and cardiac output is decreased, myocardial depression, there will be global ejection fraction decrease and GEDV, global and diastolic volume index and cardio-renal syndrome. It affects gastrointestinal or visceral system by forming ascites and gut edema, malabsorption and ileus, decreased bowel contractility, increased intra-aortic pressure and abdominal perfusion pressure is decreased, enteral feeding intolerance, intestinal permeability is increased, bacterial translocation, splanchnic microcirculatory flow is decreased, and indocyanine green distribution is decreased, and pH also is decreased. It affects abdominal wall by tissue edema, poor wound healing, wound infection, pressure ulcer, and abdominal compliance is decreased. Respiratory system is affected by pulmonary edema and pleural effusion, altered pulmonary and chest wall elastines. PaO2 is decreased and PaCO2 is increased. PF ratio is decreased. Extravascular lung water is increased. Lung volume is decreased. Prolonged ventilation and difficulty in weaning. And work of breathing is increased. It affects CNS by cerebral edema, impaired cognition and delirium. ICP and IOP are increased, whereas cerebral perfusion pressure is decreased. Intracranial hypertension and intracranial compartment syndrome can occur. Ocular compartment syndrome may also occur. It causes hepatic congestion, impaired synthetic functions, cholestasis, cytochrome P450 activity is decreased, hepatic compartment syndrome may occur. In endocrine system, it causes release of pro-inflammatory cytokines like interleukins 1b, interleukin 6 and TNF alpha. Renal system is mostly affected by renal interstitial edema, increased renal venous pressure, decreased renal blood flow, increased interstitial pressure, salt and water retention, uremia, glomerular filtration rate decrease, renal vascular resistance is increased and causing renal compartment syndrome. Coming on to the management of ROSE. ROSE is the strategy forwarded by Malbrain et al. ROSE stands for initial resuscitation phase. In the initial resuscitation phase, life-saving resuscitation phase, the focus is on patient rescue and the early adequate fluid management with a 30 ml per kg in 1 hour according to the sepsis guidelines, or fluid challenge bolus at a rate of 4 ml per kg in 5 to 10 minutes. This is in the initial few minutes, and next comes the optimization phase. In the optimization phase, there is avoiding fluid overload by fluid creep, aiming for a neutral fluid balance. Next comes the stabilization phase. In stabilization phase, it is late conservative fluid management is defined by 2 consecutive negative fluid balance within first week. And the last is evacuation phase. In this, active late goal directed fluid removal or negative fluid. This is combined with the life cycle of a ROSE. That's why it's termed as ROSE. ROSE by Malbrain et al. Aim resuscitation phase aim is to fluid treatment is resuscitation and correction of shock with achievement of an adequate perfusion pressure. In optimization, fluid should be administered according to the individual needs and reassessed on regular basis, and aim to provide water and electrolytes to replace ongoing losses and provide organ support, and in evacuation phase, removing excess fluid by diuresis and ultrafiltration. Further clarifying this resuscitation phase, salvage or rescue treatment with fluid administered quickly as bolus for 4 ml per kg over 10 to 15 minutes. The goal is early adequate goal-directed fluid management. Fluid balance must be positive, and suggested resuscitation targets are MAP more than 65, cardiac index more than 2.5 liter per minute per meter square, pulse pressure variation less than 12%, and left ventricular ejection left ventricular end diastolic area index more than 8 centimeter per meter square. During optimization phase occurs within hours. Ischemia and reperfusion, degree of positive fluid balance may be marker of severity in this phase. Risk of polycompartment syndrome, unstable compensated shock state requiring titration of fluid to cardiac output. Targets are MAP more than 65 millimeters of mercury, cardiac index more than 2.5 liter per minute per meter square, pulse pressure variation less than 14%, and left ventricular ejection end diastolic area index 8 to 12 centimeter per meter square, intra-abdominal pressure less than 15, and abdominal perfusion pressure is calculated more than 55. During stabilization phase evolves over days. Fluid therapy only for normal maintenance and replacement. Absence of shock or threat of shock. Monitor daily body weight, fluid balance, and organ function. Targets include neutral or negative fluid balance, extravascular lung water index less than 10 to 12 ml per kg, pulmonary vascular permeability index less than 2.5, intra-abdominal pressure less than 15, and abdominal perfusion pressure more than 55, colloid-oncotic pressures more than 16 to 80, and capillary leak index less than 60. During evacuation phase, patients who do not transition from the ebb phase of shock to flow phase after the second hit develop global increased permeability syndrome. Fluid overload accumulation causing end organ dysfunction, requires late goal-directed fluid removal to achieve negative fluid balance. Need to avoid over-enthusiastic fluid removal resulting in hypovolemia. Recommendations are a goal of 0 to negative fluid balance by day 3 to keep the cumulative fluid balance on day 7 as low as possible. Diuretics or renal replacement therapy in combination with albumin can be used to mobilize fluid in hemodynamically stable patients with intra-abdominal hypertension and a positive cumulative fluid balance after the acute resuscitation has been completed and the inciting issue or source control has been addressed. Codman et al. Suggested PAL approach, that is high PEEP for 30 minutes to drive the fluid from the alveoli to the interstitium, and albumin administered at a rate of 2 into 100 ml, that is 20% albumin over 60 minutes on day 1. Then titrated albumin to more than 30 gram per liter to pull fluid from the interstitium to the circulation. And L in PAL comes for furosemide. Infusion started at 60 minutes after albumin at 60 mg per hour for 4 hours, then titrated between 5 to 20 mg per hour to maintain a urine output of more than 100 ml per hour. Use of this approach in patients with acute lung injury as a part of pilot study was associated with a negative fluid balance, a reduction of extravascular lung water index and intra-abdominal pressure, and decreased duration of mechanical ventilation without compromising organ function. So we do practice this by doing following things. Fluid should be regarded as drugs and managed according to the principles of fluid stewardship. Use infusion pumps or syringe pumps for accurate delivery. Maintenance fluid is given at a rate of body weight plus 40 ml per hour. During, if any of the signs of fluid accumulation syndrome sets in, we should decrease the fluid intake to previous hour's urine output plus 10 to 20 ml per hour in order to compensate for the insensible loss. So net effect will be an isobalance or a negative balance. Low dose of dobutamine for the first 24 hours at a small dose of 5 microgram for 6 hours and then taper. During the resuscitation, after the resuscitation, most of the heart will be in a stunned stage, causing the decrease in causing global hypokinesia. This will be able, dobutamine will be able to overcome this stunned phase, and this will help in urine output and after all the circulatory effects. Lasix, we start at a rate of 40 mg per hour. We titrate at for a urine output of more than 75 ml per hour for a consecutive 2 hours. We can give FFP instead of albumin in PAL. The only problem is if we use FFPs, first 2-3 days the uremia will increase, then only it will start decreasing. But if we are using albumin directly instead of FFPs, this increase in uremia will not be there. Then we can give renal protection drugs like soda bicarb in order to prevent metabolic acidosis, calcium and essential amino acids and omega-3 fatty acid as a renal protection drugs. Thank you all.